Okay, which of the following is not a local contributory factor for periodontal disease?
D.
Well, if I
It's A.
I can't advance my slide. Well, you know it's A because I already showed you the slide accidentally. It's going to be one of those nights. Okay, dental biofilm is not a local contributory factor because it is the primary causative factor. All right, and if anybody ever misses that question, I will personally smack you on the side of your head. Well, okay, which of the following is not true of calculus? Okay, I'm going to stop and I'm going to try and reload this. How does that go? This is going to be a long evening otherwise. I don't want you guys to see the answers before they're supposed to be up there. So you don't see a slide anymore, is that correct?
Yeah.
All right. Oh God, I'm sorry, guys. Nope, that's not it either. Okay. I know you've got review PowerPoints for the test already posted, and you already have also a review YouTube, recorded YouTube. So you should have all the material that you need. All right, local contributory factors for perio disease. All right, what is calculus? Is that a local contributory factor or a primary?
Not moving forward.
You said it was before.
It was before, not now.
Is it now?
Yeah.
Okay, I'm sorry. There, I have, even though I only have one, I put one up on my desktop. When I go to share, there are 3 of them. So I never know which one to share. Okay, as you can find out. All right, so we're talking about local contributory factors. What is the primary contributory factor?
Biofilm.
Always, always, always biofilm. That's right. So contributory factors are more of a localized things, and there can be local Factors, things that can increase plaque deposition, can increase plaque retention, things that inhibit biofilm or plaque control, as well as things that contribute to the development of gingivitis and periodontitis. So all of those can be considered local contributory factors or systemic contributory factors, because think about some of the medications. But contributory factors do not initiate the gingival inflammation. They increase plaque accumulation and may make biofilm or plaque removal more difficult. So the presence, you need the presence of established periodontal disease, okay, to have breakdown. It increases the possibility of developing periodontal disease. You have to have gingivitis in order to get periodontal disease. You have to have gingivitis first. And sites that have already been affected by periodontitis, even though they are stable, are at greater risk for future episodes. And there's lots of contributory factors. You don't need to even look at this. This is just one of those things that I found online. You know, root anatomic factors, and then different anatomic factors. You've got contributory factors here, and just a little bit of everything. So we're going to talk about the contributory factors of calculus, anatomic factors, iatrogenic factors, and traumatic factors. So the book goes into each one of those, and we're going to talk about calculus first. All right. Again, the old-fashioned name of it is tartar. I do not want you using the word tartar to other professionals. It makes me cringe. Just makes me cringe because it's not a real term. Okay, it's a lay term, but it's a contributory factor. It's not the cause. Calculus is not the cause of the disease. Okay, what is the cause of the disease?
Biofilm accumulation.
Biofilm, yeah, it's the bacteria, exactly. All right, but calculus brings on its own bacterial challenge because it's mineralized or calcified dental plaque, and it is always covered by biofilm or plaque. Calculus is always covered because it's rough and it's porous. It's like a sea sponge that's just hard. Okay, and it's got all sorts of little holes in it if you look at it microscopically. And because it's porous, it has reservoirs for bacteria, and that can retain toxins. Now, just as a factoid, radiographic calculus is only 45% visible on radiographs. 45% of it is visible on radiographs. The board likes bringing up this fact. So if you can see radiographic calculus and it's in one spot and that's all you see, it might just be a localized area, but you can say, oy vey, okay, I might have my work cut out for me. Different amounts of calculus. All right, so right now we would make this a difficulty 2 for you. Starting in the summer, it might be a difficulty 1 if this is the only place they have deposit. This would be a difficulty 2, depending on what was subgingivally. Difficulty 3, again, depending on what subgingivally, or a difficulty 4. So supragingival calculus, the source is saliva. Okay, the formation source is saliva. You've got your crown, any exposed roots, any prosthesis in your mouth, and restorations. All right, it is heavier in areas adjacent to the salivary gland. So that is your Stenson's duct and your sublingual caruncle. Supragingival calculus is 30% mineralized. It starts, actual mineralization can start very soon, but it takes about 12 days or less to really form. Supragingival calculus starts forming as a yellowish white color versus subgingival calculus. Instead of it being derived from saliva, it's derived from the gingival crevicular fluid as well as inflammatory exudates. It can be in rings, ledges, or veneer form. Now, unlike the supragingival calculus, Remember what that, how much that was mineralized? 30%. Subgingival calculus is mineralized 60%. So the more it's mineralized, the harder it is. So think about subgingival calculus, it's twice as hard or dense as supragingival calculus, and it's subgingival, so you can't reach it because you've got gum tissue in the way. But 60% mineralized, it contains more calcium, magnesium, as well as fluoride, okay? Different types of attachment into the root surfaces. You've got mechanical locking into areas of cementum resorption, or areas that we have removed with our scalers and curettes. It can attach to the organic pellicle, and there is penetration into the bacteria that is still being researched. That's not a common conception. But calculus is, again, a contributory factor because you've only got one primary factor. Now, that was calculus. Anatomic factors. What are these guys?
Enamel pearls.
Enamel pearls usually occurring in the furcation areas of teeth. So we've got root morphology, we've got anomalies, which is a deviation from normal. We've got your cervical enamel projections, which is what this bottom picture is really showing you. This is a cervical enamel projection here. You can see the CEJ doesn't go straight across, it dips down. Can't have attachment on enamel, so that is a potential furcation area. Cervical enamel projections are, again, in the furcation area, you've got enamel pearls, those deep mesial grooves on the maxillary first premolars, and then the furcation areas, which form a cul-de-sac into the furcation area. Okay, a little cul-de-sac here. It's not completely open. What other is the, that I didn't mention here, that palatal gingival groove? Where are those? Now it says palate, so you know it's on the palate, which is probably maxillary, but what teeth most commonly have palatal gingival grooves?
Central incisors.
Internal incisors.
Lateral maxillary. Fatima's got it. It can be on the central incisor, but it's most common on the maxillary laterals. So anatomic factors. Tooth position. Can you even reach where you're trying to get at? Then we have iatrogenic factors. Those are caused by the dentist or by us, the dental hygienist. So let's take a look at this. This is a canine, right? A canine exposure. So let's take a look at this exposure. And you've got some horizontal overlapping here and a little bit here, which is fine. But what is the, when you're doing your technique, what would you say about this? Anything?
There's an overhang.
Well, no, this would be the pathology, yeah, in here. For here, you've got an open thing here, but I'm talking about just the technique for taking this radiograph.
Horizontal placement.
It would be not necessarily placement, it's really with the cone, but you've got horizontal overlap here, and a little bit of overlap is fine, but this would be a critical error because you can't see any of the enamel, and the overlapping goes almost all the way up to the root. So a little bit of overlap we can forgive, a lot of overlap we can't. And remember how to open and reduce that overlap by opening up the PID. So it's more open towards the anterior. So you're angling it. Does that sound familiar?
Yeah.
Yeah, okay, sure it does. Okay, iatrogenic factors. This is an overhang. Gingival injury, okay, is also an iatrogenic. Iatrogenic factors, exodontics. That's when an extraction can affect adjacent teeth and the attachment apparatus is damaged. The dentist, they just do the extraction. They don't look on the mesial of one tooth and the distal on the other tooth to remove the calculus from the adjacent teeth. They're just extracting the teeth. Drives me nuts. All right, so it's important that you as the clinician are looking at these plaque retentive surfaces and what you can do if they're fixable, what you or the dentist can do. Orthodontics, okay, look at all those plaque retentive areas. Oh my goodness. Where do you start? Now, traumatic factors. The causes: trauma to the periodontium, loss of attachment apparatus, toothbrush trauma, factitious disease. The patient's doing it to themselves, either with scratching the gingiva, gouging it with a toothpick, something like that. The patient is doing it to themselves. Food impaction areas, uneven marginal ridges, I have seen as a board question more than once. Okay, that creates food impaction. When the occlusal margins, the mesial marginal ridge isn't butt up exactly at the same level of the distal marginal ridge behind it, type of thing. Chemical injury, patients do crazy things, putting aspirin directly on a sore tooth. They can have chemical burns. Tartar control formula toothpaste, sodium lauryl sulfate, potassium nitrate have been known to create sloughing of the gingival tissue, as does the essential oils down in Listerine. Occlusion, if it's off, it can cause mobility. And it can involve the PDL. Oral piercings are a big one, okay? Clanging on the teeth. It's interfering with speech, the tongue, and everything else. So it can create recession also, especially on the mandibular anteriors, depending on where the button is, if it's on the tongue or if it's on the lip. All right, let's get some questions. All the following are local contributory factors for periodontal disease except one. What's the exception?
Dental plaque.
Yep, because that is your primary factor. Which of the following sources accounts for the mineralization of supragingival calculus?
Saliva.
Yes, saliva. The plaque on the surface of calculus contains living bacteria and is detrimental to the tissue. Therefore, calculus is a primary etiologic factor for periodontal disease.
True, false. P.
B.
You got it. You got it. That was a good one. All of the following are anatomic factors that may predispose a site to periodontal disease except one. Which is the exception? Anatomic factors.
B.
Okay, so this was a trick question. Okay, whoops. Anatomic factors, rough surfaced composite filling. The occlusal of the filling is an anatomic factor, but it's not part of the tooth. It's the man-made part of the tooth. So that would be kind of an iatrogenic thing. And this would be, when you're looking at this, guys, it would be rule out. You know that anatomic factors You know, tooth rotations, you know, those grooves, you know, the mesial of 5 and 12. So really the only thing that you might be questioning would be this one. So that would be the best choice. It might not be a good question, but you're looking at what is the best out of what you've got. All of the following traumatic factors may predispose a site to periodontal disease except one, which is the exception.
A.
Traumatic factors. Okay, so in office bleaching, we haven't gotten into that, but that can burn the gum tissue. And I was watching like a CSI or Bones or one of those things. And teeth were falling out of this dead body and they didn't know why. And it turned out, I don't know if it's true, I doubt it, but they were over whitening and it dissolved everything. Never heard of that one before on a murder mystery show. Traumatic factors, tongue piercing, yes. Food impaction, yes. So again, the best would be this, and that wouldn't be traumatic factors. That's just a bioretentive surface. You see how to look at these a little bit differently? And that would be considered an iatrogenic. Okay, blank occurs on about 5 to 8% of the maxillary incisors. It is a deep groove on the lingual surface where plaque can accumulate and lead to a deep pocket. Which term does not apply to this groove?
Buckle?
The buckle, yay! It's a palatal gingival. Okay, blank has enamel in the furcation area of the root, the extension of enamel from the CEJ apically to the furcation.
Enamel first.
Okay, so we've got an enamel pearl. What is that?
A?
Or a CEP, the enamel, cervical enamel projection, and that is the better choice. An enamel pearl is that little outgrowth of enamel, so it's a big bump. It's like an enamel pimple. Versus this is saying it's an extension here, so it's using the word an extension from the CEJ, and this is a cervical enamel projection. So these are when you're facing questions where you don't even know what the answer is. It's like, I don't even know what they're talking about. Take a look and what do you know? Okay, what can you link from the question to the possible answer choices?
What was C?
Yeah,
What was the meaning of C, if you don't mind telling us?
the cul-de-sac is what they called going into the furcation. So this is, I'm sorry, my mouse is not wanting to work either. So this is the root surface here. And the cul-de-sac, okay, this is the root trunk. And the cul-de-sac is right here. You can get your explorer right into that furcation when it's a grade 1 furcation area, but it doesn't go all the way through. Kind of like a cul-de-sac. It's, where am I? Looks like that on the inside. Okay. Cul-de-sac. Okay, which again, a negative, which is not characteristic of subgingival calculus.
B?
So we're talking, oh, supra. I'm sorry, I said it wrong. Supra. Yes, because that's sub. I was thinking sub. Which of the following sources accounts for the mineralization of subgingival calculus?
D?
D.
D.
Which one is not a correct statement about dental calculus?
A.
which is not. And it's a porous. It's porous. Okay, any questions on that chapter?
No, thank you.
Oral systemic. Okay, we know that there's an oral systemic leak. And in the presence of local irritating factors, systemic diseases can increase one's chances of developing periodontal disease. Doesn't mean you're going to be getting it. The presence of a systemic disease may make the host immune response to biofilms even greater compared to when the systemic disease is absent. So for periodontal disease to occur, bacteria must be operating on a susceptible host. Not everybody is going to get periodontal breakdown given the same conditions. Genetics plays one factor in it. Some people's genetic makeup increases their chances of getting periodontal disease. Those individuals, okay, will have periodontal disease even after practicing aggressive oral care habits. So interleukin-1, we discussed that, okay, is one of those genetic factors, and that's if you are an interleukin-1 gene positive person, you're more likely to develop periodontitis. Genetic testing and early interventions can help avoid periodontitis in susceptible people. So we're not randomly testing people. We're not randomly putting everybody on antibiotics and things like that, but we are investigating. Some congenital diseases have periodontal manifestations, such as that hereditary gingival fibromatosis and Down syndrome. Studies have demonstrated that as age increases, the risk of having periodontal disease also increases. It seems, at least in the United States, that males have more severe perio than females, and there's no firm evidence linking race to the development of periodontal disease. Stress plays a factor. Cortisone is suppressed. Stress also makes the individual less concerned about their oral hygiene as well as their diet. Diabetes, both types 1 and 2, increase the risk of perio disease by reducing the body's ability to fight infections and impair wound healing. So diabetics with glucose levels that are poorly controlled are at a higher risk for periodontitis than diabetics with good glycemic control. And diabetes has one of those bidirectional links. The more controlled the diabetes is, the more controlled the perio is. The more controlled the perio is, or the more uncontrolled the perio is, the more uncontrolled the glucose level is. So that was the endocrine system. Hormones, an imbalance or a change in the levels of progestin and estrogen worsens the gravity of gingivitis and periodontitis. So we've got pregnancy, especially in the second and third trimesters, the use of oral contraceptives, puberty, more so in females, and menopause because of a decreased estrogen level. That can also deal with bone density. We have different medications too. Some of these medications, like the bisphosphonates, help improve bone mineral density because it prevents the activity of osteoclasts, which means cells only have a certain lifespan. And if you're taking a medication that is making these cells last forever, all right, there's no osteoclast, there's no cleanup of things when they finally die out because you don't have those osteoclasts to resorb it. So with the inhibition of osteoclasts, there may be no osteoclasts left to eat away the necrotic bone. So new bone is laid over the diseased bone, and it's called bisphosphonate-related osteonecrosis of the jaw. And if you ever have a patient that has taken bisphosphonates, we have a paper release form that the patient signs. IV bisphosphonate seems to be the culprit to increase the risk more so than oral bisphosphonates. It's lower risks in persons who have been taking the oral bisphosphonate for less than 3 years. So what the doctors are doing is they're only putting people on bisphosphonates, both men and women, for a shorter period of time. It used to be you were on it for the rest of your life. Now they're saying 3 years. Dentoalveolar surgical procedures may precipitate, okay, this bisphosphonate-related osteonecrosis of the jaw. We are doing hygiene. We're not working on the bone. We're not extracting a tooth. We're not doing a crown prep. We're not doing implants, those type of things, or periodontal surgery. So hygiene is pretty safe when it comes to this. HIV and AIDS, okay, they're immune suppressed, so they are going to be more susceptible to the necrotizing diseases. Cigarette smoking and drug use. A lot of it causes xerostomia. It increases vasoconstriction, so there's not a lot of blood circulation, and that in itself will delay healing of the gingiva. And in the United States, about 53% of periodontal cases are attributed to smoking, right? Smokers are 2 to 6 times more likely to have periodontal destruction. Then there's smokeless tobacco as well, which can lead to oral cancer. Marijuana smoking, they're still investigating, as well as the e-cigarettes. They're looking at the e-cigarettes more for popcorn lung and other things going on. But cigarette smoking increases the smoker's risk to periodontal disease. And the old statistics are, okay, for every 10 years of smoking, a person can expect to lose 1 tooth. So if they've been smoking for 30 years, they've probably lost about 3 teeth just because they've been smoking and periodontal disease. Alcohol consumption can make the individual not care about their oral hygiene and nutritional requirements. It disrupts bone metabolism and healing. It disrupts blood clotting, and it interferes with the normal functioning of the neutrophils. Obesity, again, this bidirectional association between obesity and periodontal disease. The plasma levels of the TFN tumor, do you remember what that stands for? Who can tell me? Tumor. Somebody's going to look that up and tell us, okay? Anyway, the TNF are elevated, which leads to hyperinflammatory states that in turn increases the risk of periodontal disease because your body is on alert. Other systemic factors for periodontal disease, you've got your hematological disorders, your nutritional status, xerostomia due to medications, which is practically anything the patient takes, and then gingival overgrowth due to drugs. Okay, and those gingival overgrowth drugs, we've got anticonvulsants, immunosuppressants, and calcium channel blockers. Okay, so although inflammatory periodontal diseases are local infections of the gingiva and bone, it's been shown that the presence of periodontitis may itself be a risk for other systemic diseases. They are finding bacteria that originates in the mouth and is supposed to only be found in the mouth. They're finding it in other parts of the body, which is where we're getting this research from. So, systemic diseases and pregnancy-related problems associated with perio. We've got diabetes, cardiovascular disease, respiratory diseases, Alzheimer. It's been linked to Alzheimer's, as well as adverse pregnancy outcomes. What is the adverse pregnancy outcome? What would that be?
The dentition of the child?
No. That could be one of them. Not what I'm after, though. I'm a woman.
Premature?
Factor. You got it, Katerius. You looked it up. Okay, TNF. Thank you. I'm pregnant and I have periodontal disease. What am I at risk for?
The adverse pregnancy outcomes.
Yeah, what is the adverse pregnancy outcome?
Oh,
Prematurity?
Premature.
Thank you. Yes, prematurity, preterm labor. Because of the prostaglandins going on, your uterus is going to contract because of these inflammatory chemicals. Okay, so this was one of the first systemic related situations with periodontal disease that came up. And I was a new hygienist when this was happening. This was in the very early 80s when this was discovered. You know, the healthier your mouth is when you are a pregnant mother, the better chance your child has to go full term. So it's premature low birth weight and it's the low birth weight that is the associated with the periodontal disease because they are premature. All right, diabetics, poor PMN reduction, glucose levels, again, in diabetes needs to be maintained. Cardiovascular disease, they're finding the bacteria in the mouth, in the atherosclerosis, as well as the thromboembolisms. They're finding oral bacteria in this stuff and our clogged arteries and thromboembolisms. Bacteria from the mouth is found into the lungs, especially if you're hospitalized. Alzheimer's, inflammation of the central nervous system. You've got those gram-negative pathogens from the oral cavity traveling to the brain, which can injure brain tissue. This is still kind of out there. It hasn't been, it's not, what am I trying to say? It hasn't really been proven. We have to wait for people to die in order to look at their brains. Adverse pregnancy outcomes that we talked about, elevated prostaglandin levels, preterm low birth weight. All right, let's get to some questions. The following are at a higher risk for developing periodontal diseases, except so you've got all sorts of stuff here.
B?
And it's B because it was saying normal levels. 49, she hasn't hit menopause yet. It would have been different. It would have been all of the above are susceptible if it said that she was in menopause. David lives with his 50-year-old mom who has stage 4 cancer. 6 months ago, he was fired from his job and has been unemployed. 2 days ago, he came into the office with inflamed gums. Which of the following factors do you think puts him at risk for developing an inflamed gum? Which of the following? So this isn't all of the above.
D.
Not pick all that are applicable. So what is the best one? Increase in cortisone, which is an immunosuppressant. You guys rock. The following is true about cigarette smoking with regards to periodontal disease, except
B?
what are they talking about with B?
The osteoclast.
Yes, and that's the osteoclast, and that's the bisphosphonate.
Yeah.
Okay, what method of decreasing the risk of periodontal disease? Which of the following is a method?
All of the above.
All of the above. Periodontitis itself can be a risk factor for other systemic diseases. That's a true or false. Parkinson's disease is a systemic disease associated with periodontal disease.
C.
B.
Because we talked about
So the
Alzheimer's,
first one
not
is true. Parkinson's disease itself is not associated with periodontal disease. It's the patient's lack of oral hygiene and some of the medications that they're on. Which of the following is a systemic disease that's been associated with periodontal disease? Systemic disease.
A.
Got it.
Oh yeah, I meant cardiovascular A. Yeah.
Well, you said A.
Yeah.
Oh,
Why
okay.
did it say? Oh
That's what I heard. Did you say AIDS?
no, A.
Oh, okay. Oh, well, periodontal disease has been associated with blank blood glucose levels in diabetic.
Higher.
B.
B.
Higher, yay. The elderly who live in nursing homes are at high risk for developing what? A respiratory disease due to the lack of oral care, which reduces bacterial burden.
A.
C.
COPD.
And that's pneumonia, because they're aspirating it into their lungs. They're aspirating the bacteria that's in their mouth, in their lungs. Okay, so just make notes of things that you want to kind of look up. It's been estimated women with periodontal disease are blank times more likely to deliver premature infants.
A.
I couldn't remember this one myself. Preterm and blank are both adverse pregnancy outcomes.
D.
D, yep. Okay, can we go on?
Yes, please.
Periodontal diseases, okay, are microbial infections in which the microorganisms act in concert together with the host's reduced capacity to resist disease. That is a classic definition. It doesn't say anything about apical migration of the junctional epithelium, but it's a microbial infection, yes, that works with the host's capacity to resist disease. So can you see how you can pick out words here? This is something you may have never seen before, and they're going to have to add, and you might get a, is this a true or a false statement? So you've got gingivitis and periodontitis.
Professor,
Yeah,
can you go over the previous slide, please? Thank you.
what do you mean?
I meant the next slide.
Am I going in the wrong direction?
Yes, it was chapter 7, actually. Yes, this one. Can you go over this one, please?
Oh, yeah, microbial infections. Okay, periodontal diseases are microbial infections. Yes, they are. In which microorganisms act in concert with, now in concert, think about a symphony band, okay, or symphony orchestra. Everybody's working together. All right, so that's what in concert means. So these microorganisms act together with a host's reduced capacity to resist disease. So you've got a bacterial infection and then you've got your immune system. If your immune system can't fight the bacterial infection, you're going to get breakdown. If your immune system is still good and can fight off those microbial infections, you won't get disease. So it's who's winning? Is it the microbes or is it the immune system? And if the host, if that's got a reduced capacity to resist disease, the microbial infection is going to take over.
Thank you, Professor.
And somebody else, if it doesn't come, if I'm just rambling, somebody else chime in, let us know, because somebody else might be able to explain it in 5 words or less, and the light bulb will go off. Okay, you need to know this. Initial lesion, early lesion, established lesion, and advanced lesion. The advanced lesion is periodontitis. The early lesion and initial lesion is gingivitis. Okay, acute, this is chronic, and this is periodontitis. So we're going to look at each one of these because this is going to come back and haunt you for your boards also. So the initial lesion represents the first phase of the pathogenesis of periodontal disease, and it's subclinical, right? It's reversible. It's predominantly PMNs, your first line of defense. It's acute inflammation. You've got vasculitis. Things are swollen, okay, to increase the amount of fluid coming through the connective tissue. So you've got also an increase in gingival crevicular fluid. Your early lesion represents the second stage, and that phase is approximately 60 to 70% of the collagen is lost in that connective tissue. So think about that sulcular epithelium. That collagen is being lost, and it's the first clinical signs of gingivitis. It's still reversible. So the initial lesion, 2 to 4 days, is subclinical. Early lesion is the first clinical signs of gingivitis. The established lesion is chronic gingivitis. And the established lesion can remain there for years without transitioning into periodontitis. That again is an immune host response. We don't know how long this established chronic gingivitis is going to last. It might be a year, it might be 12 years, who knows, before it transitions into perio, full-blown perio. Then the advanced lesion, unknown, don't know. The fourth and final stage, you've got bone loss. So undisrupted biofilm it creates an acute inflammatory host response. In the absence of good oral hygiene, the acute inflammation becomes chronic. First stage is acute, okay, very angry. It stays there, so that becomes chronic. It's long lasting, and its associated tissue damage can quickly become irreversible if it stays there long enough. So that's when when it's irreversible, it's periodontitis. So you've got your biofilm, then you've got your acute inflammation. If that's not resolved, you've got chronic gingivitis. If that's not resolved, it can turn into periodontitis. So we've got this vasodilation going with that gingival connective tissue. The vasodilation increases the permeability of the blood vessels and allows the fluid and the cells from that lamina propria or the connective tissue to mix, and this results in the characteristic signs of gingivitis. You've got ulceration of the epithelium. You're not going to see it, but that ulceration is a sign of inflammation. Swelling is a sign of inflammation. You've got an increase in the gingival curvicular fluid, and when you go underneath the gum tissue and you poke it, it's going to bleed because of the ulceration and swelling and inflammation. Gingivitis is a microbial infection that is confined to the gingival unit. There's no apical migration of the junctional epithelium. There's no attachment loss. So it's the most common type of periodontal disease. It's limited to the gingiva, does not involve the periodontal ligament, the cementum, alveolar, and supporting bone. And it does not result in clinical attachment loss. The gingival pocket, okay, is a diseased pocket, okay? It's not a sulcus if you've got bleeding on probing and if you've got inflammation. It's a gingival pocket, okay? So sulcus is healthy, pocket is not healthy. So it's not a true pocket because you don't have any apical migration of that junctional epithelium. So we've got our, excuse me, plaque-induced gingival diseases. Begins at the gingival margin. What happens on top of the gum line has a direct effect with what's going on below the gum line area. It only develops in the presence of bacteria, and again, it's reversible, and it's usually quickly reversible. So we are the ones that are making the clinical determination, and it usually starts, gingivitis usually starts in the interdental papilla area. That's where that caul is, where you want to angle that probe into the caul and straighten it up just a little bit to make sure you're getting that scooped out area. It's non-keratinized, it's very thin, so that will actually show first. We've got our medications that you need to be aware of, as well as what they do. Hormone-related gingivitis. Do you remember what bug is oftentimes associated with this? What pathogen?
P. intermedia.
Yay! Who said that?
Mackenzie.
Mackenzie. Okay, because what do I call Mr. Perio? Who's the standard guy who just affects everything? All the run of the mill.
Gingivalis. P. gingivalis.
Gingivalis. Exactly. Yeah. The first clinical signs, this is a true false. The first clinical signs of gingivitis during the early stage, okay, it's the early stage is when it's seen. When the condition is seen in this stage, it is called chronic gingivitis.
A.
A.
It's A. Okay, it's the initial lesion is subclinical, the early lesion is clinical, and that is acute, not chronic. That's the established lesion. Which of the following is not true regarding the gingival pocket? Not true.
B. C.
No coronal migration of the gingival margin. Which of the following is not true? There is coronal migration of the gingival margin. And what's another word for that? What else, what is that describing? Swollen, puffy gum tissue, edematous gum tissue. It's filled with fluid. So the gingival enlargement, that's another way. Gingival enlargement, though, Fatima, is usually more of a cellular thing, like with gingival overgrowth. But the coronal migration of the gingival margin is instead of having the papilla knife-like that, it's going to be swollen. Swollen. Well, you see what I'm trying to do here. And then once the teeth are cleaned and the patient starts taking good care of their mouth, then the swelling will go down and it will appear like they've had recession.
What about bulbous? Bulbous. Can you write that as a description for the contour of the gingiva?
Oh, bulbous, absolutely.
Bulbous, yeah.
Bulbous. And these are words, I mean, Wilkins has all of these, and I've got these words also, I think in the 141 clinic help section. Go through Canvas and make copies of what you think you can use in clinic. And some of this is the clinical terms, you know, pedunculated. Do you remember what that is, type of thing? And if you don't, then you might need a help sheet. All right, because you don't have to commit all of this to memory if you know where to find it. What's the most common periodontal disease?
A.
C.
Good one, C. Gingivitis is a periodontal disease. It is a periodontal disease. It's the first stage of periodontal disease. It's the only reversible stage of periodontal disease, but it is periodontal disease. Which of the following is not a characteristic of plaque-induced gingivitis?
D.
You're saying it's not reversible? Still gingivitis.
A.
Choosing best answer is A. Remember, what happens on top of the gum has a direct effect what goes on underneath the gum line area. That bacteria is building on top of the gum and starts cascading down. Which of the following is not a type of hormone-related gingivitis associated with the endocrine system? Hormone-related.
B.
D.
B.
Oh, D.
I've never even heard of testosterone gingivitis. What percentage of collagen is lost from connective tissue in the early lesion?
D.
Oh, shoot. That's my bad. Okay. Good guess, guys.
Thank you.
Which of the following regarding non-plaque gingivitis, non-plaque induced gingivitis is incorrect?
Maybe A.
B.
No, it's A. Non-plaque induced gingivitis usually starts in the caul, the interdental papilla. Okay, so that would be plaque induced. Non-plaque induced, okay, we don't know histologically. I mean, caused by non-specific bacteria, but the recognition is primarily made histologically. So it would either be A or B because they both have histological in the answer, and then you narrow it down from there. True, false. Gingivitis is a microbial infection that is confined to the gingival unit. True or false? It is the most common type of periodontal disease.
A.
False.
A.
True.
True, true. Which of the following medications is associated with gingival enlargement?
D.
I think A. A?
B.
No?
It was all of the above. So
Even sodium.
I'm sorry?
Even the sodium?
Yep. Now, if they had it's sodium valproate as well as calcium channel blockers for blood pressure. Cyclosporin is immunosuppressant therapy, or if you've got a transplant, and then we've got our seizure medication. Which of the following most accurately describes the initial location of plaque-associated gingivitis? So we've had questions about non-plaque induced.
A,
C,
B.
Okay, now this would, again, what starts on top of the gum has a direct effect what happens underneath the gum. Okay, let's take a look at some periodontal diseases. Periodontitis, you know, is the clinical attachment loss. Primary factor, always, always, always biofilm. Secondary factor can be systemic diseases and other things. So if gingivitis goes unresolved, the inflammatory reaction can actually spread to the attachment apparatus and creating gingivitis, then that causes periodontitis. You have to have gingivitis first. So we're talking the advanced lesion, because on the other one, we were talking gingival diseases, right? The initial lesion, subclinical, the early lesion and established lesion, acute gingivitis and chronic gingivitis. So the advanced lesion is periodontitis, attachment loss. Okay, apical migration of the junctional epithelium and connective tissue, attachment loss, to form a pocket with micro-ulcerations and epithelial ridges. That sounds familiar. There's alveolar and supporting bone loss, and it's B cell, B as in boy, cell prominent. All right, look at the book. This has everything you need to know. Table 8.1. The inflammatory response progresses and destroys collagen, which allows for the breakdown of the periodontal ligament and allows for the junctional epithelium migration, the apical migration of that junctional epithelium. You've got a periodontal pocket, warm, dark, moist, hard to clean, undisturbed. Bacteria love it. Two types of pockets, your suprabony, which is horizontal bone loss, and infrabony, which is vertical bone loss. Your root surface is rough with the attachment loss and the loss of the PDLs being impregnated in them. It may have, the cementum may even have necrotic cementum. So the current theory states that endotoxins are more superficial than originally thought. So smooth glass-like root surfaces are not deemed necessary. We want to get the calculus off, but we don't want to make them glass-like anymore. Lucky for you guys. The inflammatory process, which involves your macrophages and PMNs, leads to resorption. Substances involved in the resorption, you've got your prostaglandins, your endotoxins, cytokines, and B cells. Remember, there was that prostaglandin E2 that is released by macrophages and your PMNs to stimulate osteoclasts, which in turn inhibits bone collagen formation. So prostaglandins, okay, are released. They stimulate osteoclasts. Interleukin-1 is a cytokine, and it's most important in periodontal disease destruction. You can stimulate prostaglandin E2 production, okay, with that interleukin-1, and bone loss can also be independent of active periodontitis. So sometimes it just happens. It can be localized or generalized. So that's why when you're doing your periodontal assessment, we are asking for generalized what, localized what. We want the full picture. You could be generalized health and localized advanced, because number 14, mesial, has a 6 millimeter or whatever clinical attachment loss. You don't have the same bacteria in every pocket. Horizontal bone loss, vertical or angular bone loss. Review the number of walls: 1 wall, 2 wall, 3 wall defects. So you've got a 4 walls around a tooth: the lingual, the buccal, the mesial, and the distal. So a 3 wall bony defect, you've got 3 walls remaining. A 1 wall bony defect, you've got 3 walls destroyed and only 1 wall remaining. So it's kind of opposite of what you think it would be. Factors related to the pattern of bone loss: it's the thickness of the interdental bone. The wider the bone, the more stable it can be. Narrow interdental spaces seem to be more prone to horizontal bone loss. So think about the mandibular anterior incisors are more prone to horizontal bone loss versus the posterior teeth. We've got chronic periodontitis and aggressive periodontitis now. Age is not a factor. Table 8.3. Take a look at it. The extent is localized or generalized, and then the severity. You have to name both of them. It could be generalized with no localized. If it's generalized, it's all over, okay? But we want you to be able to accurately describe what your patient is presenting with. Risk factors. Aggressive periodontitis used to be called early onset or juvenile periodontitis because it was seen in the younger set. It can be localized or generalized. It's rapid progression. They have found that there's some sort of a genetic component. Look at this. You've got your P. gingivalis, all right, Mr. Perio there, but also you've got your AA there. And there's usually PMN and macrophage defects. So your immune system is not working correctly. Table 8.4, everything you need to know. Everything you need to know. Refractory, patients not responding. Recurrent is they did respond, and now they're more likely to have breakdown in those areas. If you've had previous periodontal breakdown, that site is more susceptible to future periodontal breakdown. Peri-implant disease. There is in the new AAP classification, there is specific, if your patient has an implant, we don't have that in the template, but they have specific separate classifications around implants. Treatment of periodontitis, you all know, reevaluation in 4 to 8 weeks. How many walls remain in a 1 wall bony defect?
3.
3.
C.
This is wrong. I don't know what I was thinking. 1 wall bony defect should be 3. Vertical patterns of bone loss are associated with suprabony pockets. Horizontal bone loss is associated with infrabony defects.
A.
vertical bone loss are infrabony. Horizontal pockets are always suprabony. Which is a difference between chronic and aggressive.
All of that, yeah, all of,
So we've got different bacteria type. Okay, we've got the AA in there. The cause of the disease, it's can be genetic, age of the onset. Aggressive is usually younger versus chronic, usually. An established lesion. So which cells dominate? It's going to be either T cell or B cell dominated, because that's the language in the literature and everything that you're learning for. So it's not a macrophage dominant or a plasma cell dominant. So you can rule those out. So, is it a T cell or a B cell? We've narrowed it down to two.
B cells?
T cell.
No, T cells, it's for the HIV.
Okay, so it's B as in boy for chronic. The gingival pocket is considered a true pocket, true or false? There is apical migration of the junctional epithelium associated with gingivitis.
B?
C,
So a gingival pocket is not a true pocket. That's what we call a pseudo pocket, because a true pocket actually has apical migration of the junctional epithelium. There is apical migration of the junctional epithelium associated with gingivitis. That's false. So the correct answer is false, false. Localized periodontitis affects what percentage of the sites in the mouth?
A,
So it would be under 30 or over 30. Does everybody know what these two symbols mean?
Yes, less and
yeah,
then
less and more.
Okay, all right. I just want to make sure, because it can be confusing if you don't know what those numbers mean. Then the answers mean nothing to you. How much clinical attachment loss would you expect to see in a patient with severe periodontitis? Severe and advanced are the same thing.
greater
More
than
than
5.
5.
That was an easy one. Periodontitis can have a bidirectional relationship with systemic disease. True or false? This means that one can have a negative impact on the other.
B.
One can have a negative impact. Okay, so look at these, because this is kind of tricky. So we know that the first statement is true. It can have a bidirectional relationship. So if you've got high blood sugar with diabetes, you were going to have more periodontal disease. That's a negative impact. So the wording is off here. Does everybody understand where this negative impact is coming from?
Can you explain one more time, please, Misty?
Okay, so you can have a positive impact, which means they work together to get things better, or a negative impact, they work together to make things worse. So bidirectional, one affects the other. So in this particular case, it affects each other negatively. Blood sugar, high blood sugar will affect your system negatively by destroying your PMNs and not being able to fight off the infection. So you're going to be more prone to periodontal disease. Negative impact. Uh-oh. Okay, that was a good guess. Or Mackenzie, was it a guess?
No, I remember it from the slide a few slides ago.
What term describes patients that are unresponsive to traditional methods of periodontal therapy?
B,
Yep, refractory. Okay. Necrotizing. Okay, they're ulcerative inflammatory periodontal diseases. You've got your NUG and your NUP. Both have decrease in systemic resistance. Necrotizing ulcerative gingivitis. We've got kind of like a pseudo membrane here of dead tissue. You can see the swollen, punched out gingiva. Sometimes there's odor. There's always pain. NUG is predominantly in the younger set right now. Small gray ulcerative lesions. It develops quickly, begins at the tip of the interdental papilla, and it spreads to the gingival margin. The papillas can be punched out or cratered, but that grayish white pseudomembrane may be present. When I was in school, that was one of the hallmark things, was this pseudomembrane. The newer textbooks aren't putting that in as a cardinal sign. And it used to be called trench mouth or Vincent's disease. The causes, it's usually stress and immunosuppression, lack of proper oral hygiene, where the bacteria just take over. Your P intermedia and your Fusobacterium take over. Does that look angry or what? Okay, now this is periodontitis because there's attachment loss associated with it. Mainly seen in HIV infected individuals. With NUP, you've got a rapid loss of attachment as well as bone destruction. Causes immunodeficiency, P. gingivalis, Fusobacterium, P. intermedia. Hold on, Ms. McGraw is texting me. Okay. 3 criteria must be present: pain, bleeding, interproximal necrosis. Differential diagnosis, what does that mean? You want to rule out what it isn't. Okay, so that would be, what would it be? Primary herpetic gingivostomatitis would be one of them. Treatments, review that. We do what the patient can tolerate. We want to get them out of pain first and then slowly debride. For a NUG, it's not always a calculus driven, it's more of a soft tissue plaque biofilm driven. So they've just got a lot of stuff. Okay, what are necrotizing periodontal diseases? What's the best answer? Is D. Gingivitis, NUG, only involves the gingival unit. NUG No, this is NUP, involves the,
perio.
wouldn't it be nice if all the questions were that obvious?
Yeah.
Can you go back to the question? I'm sorry.
NUP, involves. So you've got it, you know it's not brain, you know it's not skin and feet, so you narrow it down to the attachment apparatus or the gingival unit and the attachment apparatus,
Got it. Thank you.
okay? Which is the best choice. Subsets of necrotizing periodontal diseases,
D.
NUG and NUP. In NUG, what population is most affected?
A.
The younger set, college students. In NUP, what population is most affected?
B.
B.
You got it.
C.
Let's see. The World War I.
Trench mouth, Vincent's disease. So clinical features, what does NUP have that NUG does not?
D.
Rapid attachment loss. Yep. What three criteria, this is an important one, what three criteria are required to diagnose NUG and NUP?
I think C.
B.
Okay, pain, bleeding, and interdental papilla necrosis. Okay, so again, this was the best out of all the choices. Which fungus may be involved with patients who have NUP? Which fungus? Which one of these is a fungus?
I think it's C.
C.
That's the only fungus listed.
C. Yeah.
Yeah.
Okay, that's all I got, folks. I think I'm missing a chapter. am I?
You're missing two
I'm
chapters.
missing a chapter.
2 chapters.
Missing 2 chapters. Sorry about that.
Unless you don't give it to us in exam.
Please.
So funny. Nope, we are moving on. So we've got occlusal trauma and abscesses. Abscesses, remember you've got your gingival abscess, which is usually caused by what?
Bacteria.
A gingival abscess is usually caused by something stuck in the gum line, in the gingival margin. So it's at the gingival margin. Periodontal abscess, what is the other name for a periodontal abscess?
Recession.
No,
Periapical something.
lateral abscess, because it's on the side of a tooth and it's usually in a deep pocket. And the primary cause is calculus or something in there that you didn't get out. Suppuration is a sign or a symptom of the bacteria. And then you've got your endodontic abscess, which involves the nerve of the tooth. And then occlusal trauma. Does occlusal trauma alone cause periodontal disease?
No.
No, you have to have gingivitis along with it. Okay. And that's the big takeaway from there. That's why you want to take vertical bite wings, because you want to see the PDL and see if there's any widening of the PDL. So you're looking for wear facets and other things as well. Okay, any questions?
No.
I have 3 students who said they're not coming tomorrow. So tomorrow after clinic, we'll be out on time. We'll go upstairs to 329, which is the dental hygiene classroom. And hopefully you'll get some good food and some good samples and learn a few things. Okay, well, I will see everybody tomorrow.
Thank you.
Bye.
Thank you so much, Misty.
You're welcome.
Thank you.
Thank you.